Bismillahirrahmanirrahim. Students, today we'll be discussing some more other university questions from the topic of the blood vessels. We have already covered 4 questions. So now coming to the question number 5. A 69 years old man presents with increasingly severe headaches for 2 months, especially on the left side. His vital signs including BP are normal. So there is a palpable tender cord-like area over his left temple. His heart rate is regular and no abnormal sounds on auscultation. So pulses are equal and full in all extremities, and his ESR is 110 millimeter. So what is the most likely diagnosis, and write down the possible pathogenic mechanism and the microscopic features of this disease. So as you can see in this question, there is a clue in this line that there is a palpable tender cord-like area over his left temple. It is a diagram in your Robbins in which it is the characteristic gross appearance of vasculitis, the large vessel vasculitis that involves the temporal artery, and that is giant cell or the temporal arteritis. So it is the answer of question number A, that it is the giant cell or temporal arteritis. And the answer of question number B is the pathogenic mechanism is that it is a T cell mediated immune response to an unknown vessel wall antigen. So the pathogenic mechanism, as we have already discussed in the topic of vasculitis, are the immune complex deposition. So among the immune complex related vasculitides, the large vessel vasculitis is the most common. So the answer of question number C, in which they are asking about the microscopic features. So in giant cell or the temporal arteritis, which is the granulomatous vasculitis, there is nodular intimal thickening with reduction of the lumen and occasional thrombosis. There is granulomatous destruction of the vessel wall with the infiltration of the tunica media with Langhan cells or the foreign body type giant cell lymphocytes and the plasma cell, and there is fragmentation of the internal elastic lamina. You can also draw the diagram, the histological picture that is mentioned in your Robbins. So this is the question number 5. Now the question number 6 is, a 55-year-old man presents with left-sided facial pain with palpable left temporal artery. The biopsy of the artery reveals fragmentation of the internal elastic lamina with granulomas containing Langhan and the foreign body type giant cells. So this is the same question with a little bit differences. In the previous question, they were asking about the microscopic features, and in this question, they have already mentioned the microscopic features of the disease, and the sub-parts of the question are somewhat different. So part A is that what is the diagnosis. In part B, they are asking which other condition should be considered in the differential diagnosis if a granulomatous vasculitis involves the aorta. And the third question is that list the 3 pathogenic mechanisms involved in non-infectious vasculitis. So the answer of part A is the giant cell or the temporal arteritis, and the answer of part B is the classic large vessel vasculitis, the granulomatous vasculitis that involves the aorta, is the Takayasu arteritis, which is the pulseless disease in which there is diminished pulses in the upper extremities. So in the question number 5, they have mentioned that the pulses are normal. So in clinical scenario, they give you clear-cut instructions and indications. And the answer of part C is that there are 3 pathogenic mechanisms that are involved in non-infectious vasculitis: the immune complex deposition, the anti-neutrophilic cytoplasmic antibodies, and the anti-endothelial cell antibodies. So either you can give their somewhat short descriptions, that in immune complex deposition the antibody and complement are typically detected, and their characteristic examples like drug reactions, SLE, and viral infection. And in anti-neutrophilic cytoplasmic antibodies, you can give examples of the small vessel vasculitides like the Wegener's, the polyarteritis nodosa, and the Kawasaki disease. So their characteristic type, the cytoplasmic anti-neutrophilic cytoplasmic antibodies and the perinuclear cytoplasmic antibodies. And lastly, the anti-endothelial cell antibodies, that is the characteristic example, the Kawasaki disease. Now coming to the question number 7. A 56-year-old male presents with raised voilaceous plaques over his legs and is found to be a HIV positive. A biopsy of the lesion revealed a vascular neoplasm. Further investigations revealed lesions with similar histology involving the multiple abdominal viscera. So name the likely tumor. List other 3 forms of the same disease. And which viral DNA would you expect to isolate from this tumor? So this is the characteristic appearance. They are giving you indication that the person is HIV positive and raised voilaceous plaques. That is the characteristic feature of the disease that has a patch stage, plaque stage, and the nodular stage we have already discussed. So the likely tumor is the Kaposi sarcoma, that is AIDS-related, or the epidemic Kaposi sarcoma. And the answer of part B is the other types of the Kaposi sarcoma is the classic Kaposi sarcoma, the endemic or African Kaposi sarcoma, the epidemic or AIDS-associated Kaposi sarcoma, and the transplant-associated Kaposi sarcoma. And the answer of part C is the characteristic organism that they are asking that is causing the disease. It is the human herpes virus 8 or the Kaposi sarcoma associated herpes virus. So it is the member of the gamma herpes virus subfamily, and it is transmitted sexually and by poorly understood non-sexual routes, perhaps including the saliva and the cutaneous route. So now coming to the last question, question number 8. Define and classify aneurysms. Describe the etiology and the morphology of the dissecting aneurysm and give its clinical course. So we have already discussed the topic of aneurysm. So it is basically so the etiology is that the 3 types there that are causing the weakening of the vessel wall. So the 3 etiologies are the poor intrinsic quality of vascular wall connective tissue, that could be the Marfan syndrome, the Loeys-dietz syndrome, and the Ehlers-danlos syndrome. You can also write shortly about Marfan syndrome, in which there is difficult synthesis and defective synthesis of scaffolding protein fibrillin, and in Loeys-dietz syndrome there is defect in and the mutation in the transforming growth factor beta, and in Ehlers-danlos syndrome there is defective in collagen 3 synthesis due to vitamin C deficiency. So alteration between collagen synthesis and degradation, that the extracellular matrix components are degraded with the help of matrix metalloproteinases. These are the enzymes. Whenever their concentration is increased, the components of the extracellular matrix, that are the collagen, elastin, proteoglycans, they are destroyed, and the inhibitors of these matrix metalloproteinases, whenever they are decreased, there will be the weakening of the vessel wall. And the third cause is the weakening of the vessel wall through the loss of smooth muscle cells and the synthesis of non-collagenous and the non-elastic extracellular matrix, that is the cystic medial degeneration. So in order to revise this condition characteristically occurs whenever there is ischemia of the media, because whenever there is atherosclerotic thickening of the tunica intima, there is poor diffusion of oxygen through the vessel wall, as a result of which there is ischemia of the tunica media layer, as a result of which there is degradation of the normal extracellular matrix component, and there is synthesis of non-collagenous extracellular matrix components, that are the glycosaminoglycans. So this condition is referred to as the cystic medial degeneration. And the answer of part C, the clinical course of dissecting aneurysm. So in dissecting aneurysm, there occurs an intimal tear that passes through and through the media of the ascending aorta, creating a blood-filled pocket between the layers. So this dissection can continue either in both direction, towards the heart or towards the femoral. So the dissection usually rupture outwards, but they can rupture inwards. So the clinical course, basically whenever the dissection rupture outwards, there could be a hemorrhage, which could be the pleural hemorrhage, the peritoneal or the pericardial hemorrhage, that is fatal and leads to death. And sometimes a second intimal tear occurs at some distance lower to the first intimal tear, and through which the blood enters back through, into the aorta, creating a new vascular channel that is referred to as the double barrel aorta, which can over time endothelialize and become a permanent vessel. So the dissecting aneurysm can cause the cardiac tamponade and aortic insufficiency, which have serious consequences. As you can see that the topic of the blood vessels is very important, and the university questions involve almost all the topics. Among these 8 questions, you can see that there are questions from the topic of atherosclerosis, hypertension, vasculitis, aneurysms and dissections, and the vascular tumors. So each and every topic of blood vessel is very important. So we conclude the topic of the blood vessels. Thank you so much for patient listening.